this program. Thank you, Bill.
Thank you, Joe. Welcome, everyone. Um, this is the first series of six, I want to say, for our Echo series. So we want to welcome each and every one of you. Our first presenter for this colorectal screening and awareness, we'll call it, is going to be Sandra Sivak, and we want to welcome her. She is a research coordinator at UT Health San Antonio, San Antonio's Institute for Health Promotions Research. She's working under the mentorship of Doctors Amalie Ramirez and Patricia Shalela. She earned her master's in science at the Texas State University with a focus on public health communication and promotion. She supports ongoing research studies and projects aimed at improving health outcomes across diverse populations. Her role is to inform her experience as an oncology patient navigator and her training as a tobacco treatment specialist. She provides social support and cancer-focused education to patients at the Cancer Center and to the community members throughout San Antonio and the surrounding area. So I do want to welcome her. And I'm going to turn it over to her in just a second. Like Joe said, my name is Belinda Flores, and I will be um, the person that I wanted to say navigator, believe it or not, but facilitator. I will be the facilitator for these echo sessions. Our echo sessions goes by a presenter, and then there's time for question and answer. So having said that, I think we are ready to go. Please continue to mark your session, your attendance. So just with a QR code so that we know we can give you the credit that you need at the end. So please, once you scan the QR code, you'll be able to register yourself, answer the questions, and then stay on so that you can do the post little questions at the end. Thank you so much for joining us, and I'm going to turn it over to Sandra.
And good afternoon, everyone. I am very happy to be here to discuss with you all this very important topic of colorectal cancer. I will not go into any additional details regarding introduction. I think Belinda did a great job there. If you can go ahead and go on to the next slide, please. Okay, so one of the things that we want to do before we actually get into the presentation is just kind of get a better understanding of what is cancer. So we have some familiarity with it, but how do we define cancer? So just to give you some background, the human body is made up of trillions of living cells. Normal cells, they grow, they divide into new cells, and they die in an orderly way. And during a person's early years, you'll see that normal cells divide faster to allow a person to grow. But once a person reaches a certain point, like adulthood, most of the cells divide only to replace worn out or dying cells or to, replace or to repair injuries. And cancer begins when cells in a part of the body start to grow out of control. Cancer cell growth is different from normal cell growth. Instead of dying, cancer cells continue to grow and form new abnormal cells. In most cases, this leads to the formation of a tumor. No, I said in most cases. And cancer cells can also invade or grow into other tissues, something that normal cells cannot do. Growing out of control and invading other tissues are what makes a cell a cancer cell. And then if you look here in the illustration, you see that we have the cancer cells isolated on the left side, and then with progression, they form this tumor, not in all cases. And then you'll see that it starts invading different tissues. And there's the lymphatic system and the circulatory system that these cells actually can go into or invade because they have no more space in the certain area where they originated. And once that happens, once it goes into the lymphatic system or the circulatory system, that's whenever you see metastasis. Next slide, please. Okay. So it's always a good idea to kind of have an understanding of the colon anatomy. So cancer can start almost anywhere in our bodies and can spread to other parts of the body through the blood and lymph system. But we need to have some basic knowledge about the normal structure of the colon as shown in the picture here. So the colon and the rectum are parts of the large intestine, which is the lower part of the body's digestive system. And during digestion, food moves through the stomach and the small intestine into the colon. And during digestion, the colon absorbs water and nutrients from the food and stores waste, matter of stool. And the stool moves from the colon into the rectum before it leaves the body. So So colorectal cancer is the uncontrolled growth of abnormal cells in the colon or rectum. Next slide, please. And most colon cancers develop first as polyps, which are abnormal growths inside the colon or the rectum that may later become cancerous if not removed. And some types of polyps can change into cancer over the course of several years, but not all polyps become cancer. Next slide, please. In this image, you can see abnormal cells beginning to grow in the mucosa, which is the innermost layer of the colon wall. And these abnormal cells may become cancer. These are just abnormal cells to begin with. And when cancer has not invaded nearby tissue, it is called carcinoma in situ. So that's just something that you may hear if you're ever in a clinical setting, in situ, and that just means where it started, so in place. And this stage of cancer describes how invasive, or the stage of cancer describes how invasive the cancer is in the body. Later stages mean more invasion of cancer, whereas earlier stages mean less invasion of cancer. And deciding how to treat cancer is largely dependent on the stage. Next slide, please. So for colorectal cancer, staging is based on how far into the intestinal wall the cancer has grown and whether it has reached nearby structures, such as spreading to nearby lymph nodes or other organs in the body. And when cancer spreads to other parts of the body and forms new tumors, this is when, again, metastasis. So here in the image, we have stage 0, 1, 2, 3, and 4. And in stage 0, we see that, okay, the abnormal cells are still in the mucosa. They really haven't migrated anywhere, or yeah, anywhere other than where they started. And then in stage 1, you see the progression slowly going into the submucosa. And then and then with stage 2, it starts going into even deeper layers. The same thing with stage 3 and stage 4. And if you pay close attention to stage 4, this is where you see that it's already starting to go into the lymphatic system and to those little green lines and the little red lines that depict the circulatory system and the lymphatic system. So once those colorectal cancer cells go into these systems, then they can go into different parts of the body. It's kind of like a transport system. It's like a highway. They hijack that highway and then they can go into different areas of the body. So you can see a colorectal cancer cell in the lungs. You can see it in the liver, even in the bone. Next slide, please. And so this right here, it is ideal to have an understanding of what is to expect with these types of cancers. So the new cases, we have a good understand, or I guess a good point of view of how their individuals are getting affected. So gender-wise, it affects both women and men. We really don't see a trend as it affects one gender more than the other. And to put that more into like a ratio, so 1 in 24 men and 1 in 26 women in the US will develop colorectal cancer in their lifetime. And colorectal cancer is the third most common type of cancer in the United States. Next slide, please. Right now, we're seeing that every 3 minutes, a person is diagnosed with colorectal cancer, and that translates into 154, over 154,000 individuals that are diagnosed with this type of cancer. And remember, this is colon and the rectum, cancers in the colon and rectum. And 1 in 3 adults do not follow screening guidelines as recommended, regardless of what these numbers look like. Next slide, please. Colorectal cancer is the second leading cause of cancer death in the United States. I do have a lot of individuals whenever I do the presentations ask, what's the first leading type? So I'll just say it right now. It's lung cancer. Okay, next bullet. About 52,900 people will die due to colorectal cancer this year. And that means that every 10 minutes, somebody is going to pass away because of colorectal cancer. Next slide, please. And as daunting as that information is, I do just want to highlight that there are more than 1.5 million colorectal cancer survivors in the country who are living longer and healthier lives than before. And this is because of the advances in science and in medicine and screening. Next slide, please. So, one of the main themes of this specific presentation is early detection saves lives. And when colorectal cancer is found early, the 5-year survival rate is 91%. And all this means is that 5 years after the individual was originally diagnosed, about 91% of those individuals are still alive. Next slide, please. And now we're just going to get into the risk factors. First, we're going to cover the risk factors that we cannot change, and then we're going to go over the risk factors that we can change. So the first risk factor, and I know none of us want to hear this, is getting older. Um, it just happens. Our cells start to slow down in the work that they do, and that also means our immune cells. And then also racial and ethnic background. So yes, there are certain ethnicities and races that have a higher chance of developing this disease compared to the rest of the population, and those are African Americans and Jews of Eastern European descent. And then your sex at birth, that, so this one right here, this is something that used to be more relevance, but now at this point, it's we're seeing the same outcome, like the same result in both men and women. Next slide, please. And the family history. So family history is something that, does come into play whenever it comes to a lot of diseases, including colorectal cancer. So if your family has a history of colorectal cancer or adenomatous polyps, also a personal history of colorectal polyps or colorectal cancer, once you've had a type of cancer, you're more at risk of getting that cancer again. Next slide, please. Additionally, a personal history of inflammatory bowel disease, so ulcerative colitis, Crohn's disease, and then having an inherited syndrome or gene mutation. This also increases risk. So the familial adenomatous polyposis, these words sometimes, Lynch syndrome or hereditary non-polyposis colorectal cancer, and then other inherited syndrome or gene mutations associated with the colorectal area. Next slide, please. And these that we're going to be covering right now, so the factors that you can change, a lot of these, we have control over, so it's just important for us to have an idea of what we can do to improve our health standing and work towards a better health outcome for ourselves, for our families. And I'm just going to go through here. Some of these may surprise you, some of these you may already know, and that's perfect. So there are several lifestyle factors that have been linked to colorectal cancer. And in fact, the links between weight, diet, and exercise and colorectal cancer risk are some of the strongest for any type of cancer. Being overweight or obese increases the risk of developing and dying from colorectal cancer, and is actually higher if you fall in this category. And being overweight actually raises the risk of colorectal cancer in both men and women, but the link seems to be stronger in men, strangely. And physical inactivity. So it's very important just to kind of know, just to know that, there's that association of being inactive or having a sedentary lifestyle usually results in being overweight or obese. And then having type 2 diabetes. Of course, we know, if with the type 2 diabetes diagnosis, there's certain lifestyle factors that attribute to that also have to do with consumption and activity. If we can, oh, please go to the next slide. Thank you. Additionally, certain types of diets that include high red meat, such as beef, pork, lamb, or organ meat like liver, and processed meat, such as hot dogs and some lunch meats, so like salami, ham, can raise your risk of colorectal cancer as well. And I know when I bring that up, a lot of people are a lot of folks, they're pretty surprised. It's, it is something that we really don't consider. And also cooking meats at very high temperatures, so frying, broiling, or grilling, creates chemicals that might raise your cancer risk. But it's not clear how much this might increase your colorectal cancer risk. And then also another factor that we can change is smoking. So if you are smoking, it's recommended that you quit. And if you're thinking about starting smoking, just don't. Just that's not a good idea. And smoking is attributed to 14 different types of cancer as well. Also, heavy alcohol use. This is another a big factor. Next slide, please. So now we're just going to be covering the warning signs for colorectal cancer. And while these warning signs do not always indicate the presence of colorectal cancer, they should at least turn on that light bulb in your head that maybe it's time you see your physician or go for a checkup because these are not normal occurrences. Excuse me. And so the first one is bleeding in the rectum and blood in the stool or in the toilet after having a bowel movement, dark or black stools. It's just, and one comment that I remember somebody telling me is that, they're not going to make it a point to observe, what their, I guess, their droppings. But if you notice that something is abnormal and you have a higher risk, then that's whenever it would be, you want to make it a point to make those observations. And then finally, a change in the shape of the stool. So if it's more narrow than usual, this is something to look out for and to report. Next slide, please. Also, there's the cramping or the discomfort in the lower abdomen for a prolonged amount of time. So let's say over 5 days, you're feeling the same discomfort. That's something that you should be a little concerned about. An urge to have a bowel movement when the bowel is empty, or constipation or diarrhea that lasts more than a few days, a decrease in appetite, and then unintentional weight loss. So you're just losing weight and you're not doing anything different. That's not normal. Next slide, please. So these right here are the screening guidelines, the current screening guidelines. There used to be only 3, and now we have a total of 6. From the time the first abnormal cells start to grow into polyps, it usually takes about 10 to 15 years for them to develop into colorectal cancer. And with regular screenings, most polyps can be found and removed before they have a chance to turn into cancer. As screening can also find colorectal cancer early when it is highly curable and easier to treat. So, as I said, there are the 6. There are visual or structural exams of the colon and rectum. These tests, they look at the structure of the colon and the rectum for any abnormal areas. They're done with either a scope, which is a tube-like, it's a tube-like device with special imaging as well. And so the first one is the colonoscopy, and this is where the long flexible tube is used to look at the entire colon and rectum. And then in the second image, we have the flexible sigmoidoscopy, where a flexible lighted tube is put into the rectum and lower colon to check for polyps and cancer. And then we have the CT colonography, which is like a virtual colonoscopy. Next slide, please. And then we have the stool-based test. So these tests check the stool for signs of cancer, and these tests are less invasive and easier to have done, but they need to be done more often. So there's pros and cons. And but just so you all know, any of these screening procedures can be used to test for colorectal cancer. Next slide, please. So we're going to go just a little more in depth for each of these. So for the colonoscopy, a regular colonoscopy is recommended every 10 years, starting at the age of 45 for people of average risk. So for African Americans, it's recommended to address in this conversation about the screening guidelines with the PCP or their provider to kind of see when, based off of background and environment, when they should start receiving the screenings. If there are other risk factors, such as family history, you may want to start screening earlier, as recommended by the provider. Next slide, please. And the sigmoidoscopy is just another test that can be considered at 45 years, and it's done every 5 to 10 years or as recommended by the provider. Next slide, please. Okay. So the CT colonography exam is an advanced type of computed tomography scan of the colon and rectum that can show abnormal areas like polyps or cancer, and has a special computer program that uses both X-rays and a CT scan to make a three-dimensional picture of the inside of the colon and rectum. It's relatively new, and it doesn't require sedation or medicine to sleep or scope to be put in the rectum. It's more like a small catheter that's placed in the rectum to fill the colon with air or carbon dioxide. And this just allows for clear CT pictures. And this one, again, the recommended start date or start year is 45, and then it's recommended every 5 to 10 years, or as the doctor wants for you to have. Next slide, please. Okay, and then this is the fecal occult blood test. Probably have heard of it as FOBT. I think that's most commonly shared or yeah, described like that. And of course, you start again at the 45 years or every year as recommended by the doctor. Next slide, please. And then we have the fecal immunochemical test, otherwise known as FIT. And this one is also recommended to start at 45 years of age, and then the frequency is every year or as recommended by the doctor. Next slide, please. And then we have the multi-target stool DNA test. And this one also is one that is recommended to start at 45 years of age. And the frequency is every 3 years or as recommended by the doctor. Next slide, please. There are a few different treatments for colorectal cancer, but the most common ones are the ones that we have listed here on the slide. The surgery, radiation therapy, chemotherapy, targeted therapy, immunotherapy, and clinical trials. You may see that a oncologist will recommend either just one or a combination of these, depending on what the cancer, like the stage of the cancer and the personal history of the patient. Next slide, please. So now that we have all of this information, what can we do to reduce our risk of getting colorectal cancer? Can you go to the next slide, please? Regular screening is one of the most important things and powerful weapons for preventing colorectal cancer. And now we have 6 different ways of doing the screenings, which is amazing. And also maintaining a healthy weight. Remember, lifestyle is one of the main contributors to raising our risk factors, or raising our risk of developing colorectal cancer. And then adopting a physically active lifestyle. So doing things that require you to get up, move around. Something that makes you breathe hard or let's say like a brisk walk, something that just makes you breathe more, I guess, faster than you normally would. Activities like that can lower the risk. But one thing to also consider is the more intense the workout, the better benefit or the greater benefit. Next slide, please. And then overall, diets that are high in vegetables, fruits, and whole grains, and low in red and processed meats have been linked with lower colorectal cancer. And In recent years, some large studies with over thousand individuals have suggested that fiber in the diet, especially from whole grains, may lower colorectal cancer risk. And there's still additional research in this topic, but I do just want to highlight here the eating at least 2.5 cups of vegetables and fruits a day. This goes a long way, and it also keeps us more satisfied without having to compensate with those other foods that we know are potentially harmful, like the red and the processed meat. And next slide, please. And then, of course, avoiding excess alcohol. Um, Limit your alcohol intake to no more than 2 drinks a day if you're a man, and 1 drink a day if you're a woman. Yes, there is a difference for men and women. And if you don't drink, don't start. And then get enough calcium. So, some of the top calcium-rich foods are cheese, yogurt, and milk. And if you prefer non-dairy foods, dark leafy greens like kale, spinach, and collard greens, fortified cereals, and fortified fruit juices are also very rich in calcium. So, when you're at the grocery store and you're deciding which option to get, if you see that it's fortified with vitamin D, or calcium, just opt for that option. And then avoid smoking. Again, remember, smoking is associated with 14 different types of cancer. This also includes any form of smoking, so vaping as well. Just don't do it. Next slide, please. And so points to remember, colorectal cancer, it can be prevented. And I know that a lot there, especially in my culture, whenever we hear the word cancer, we know that cancer runs in our family. Some of us may feel like we're doomed to get cancer, and that is not the case. We can have control over our risk, and that's something that a lot of us need to come to terms with, that we can control what happens, to, at least to some extent, or at least lower our risk. We can work at it from that angle. And that early detection saves lives. Remember that finding those cancerous polyps early on and having them removed can prevent them from growing and migrating into different tissues. So early detection is crucial. And then remembering the 6 screening exams. So we have the colonoscopy, the flexible sigmoidoscopy, the CT colonography, the fecal occult blood test, the fecal immunochemical test, and the multi-target stool DNA test. The last three, these are some options that are available in, I want to say that you can do some of them even at home. You can have these kits mailed to you and you can drop them off like at LabCorp. These are alternative options that make it easier for individuals who wouldn't normally have access to this type of resource to have, especially like in rural areas. And next slide, please. And I know that we have all this information now, and now we're experts. But it's remember that ultimately it's your provider that will recommend how often you need to be screened based on your individual risk. So we recommend making sure that whenever you're at the clinic with your provider, that you are being open with them. I know that sometimes we don't think that certain history is relevant, but now knowing, what type of history to look out for that increases your risk, maybe disclosing that or sharing that with the provider so that y'all can set up a treatment or, a game plan to make sure that your screening recommendation is specific for you. It's also important to stay aware. You know your body. If you're seeing changes, any of those symptoms or those warning signs that we went over earlier, for like prolonged amounts of time, you want to make note of that. If you need to write it down, it started on this day, do that. Some of us need that because we're always on the go. And get that appointment with your provider. And if the appointment with the provider is really far out, it's always a good idea to let whoever is doing the scheduling know that if somebody to put you on a list in case somebody cancels, that they contact you so that you can get into that appointment sooner. Because I know sometimes it is a little harder to get in, a next day appointment. Um, and also visit your doctor on a regular basis. So some of us have annual appointments, and then there's others that, see the doctor every 6 months. Don't try not to miss those appointments. And if you have to, just at least reschedule. And then again, this is the example that we're setting for the people around us and our family. So it's important, to take care of yourself and don't wait. See the doctor immediately if you experience any warning signs and act now and get screened. Okay, next slide. Oh, well, it looks like this was pretty fast. I went through that very quickly. So thank you all, and I will turn it back over to Jose.
Uh, Bill, would you mind?
Sure. So thank you so much, Sandra. We really appreciate it. What a great plethora of information, just so much information that we received, especially on the importance of the screening. I want to open it up to anyone that has a question. You can either put it in the chat or if you want to unmute and ask your question, we welcome those questions. And again, we have Sandra here and others that can help us with those questions that you may have. Great, great presentation. Thank you. Um, Ms. Morales?
Hi, good afternoon, everyone. I hope everybody's doing good this new year. I did have a question. Um, my question is on the polyps. Once they do find one when you're going through colonoscopy, but they remove it, what is your chances on that's been removed? Like, I don't, that's where I'm kind of lost.
Okay, so once it's been removed, you're essentially eliminating the risk of that specific polyp developing into a cancerous, more cancerous tissue. However, if you have, there are certain conditions that will it will lead to you having many polyps, right? And the more polyps that you have that are unattended, that's where your chances are still higher of developing, the colorectal cancer. But I want to say, to being proactive in removing those polyps after they've been there for a certain amount of time and the doctor does see that they're problematic, that right there, you're reducing your risk of developing colorectal cancer significantly.
I thank you for that.
Of
Thank
course.
my
Thank you for
my
your question.
yes.
And next we have Miss Wilson.
Good afternoon. I appreciate this presentation. So I just wanted to know, like, I know my husband does Cologuard, and I haven't started like my colonoscopy because I haven't fit into that age range. Would it be pertinent to do the in-home test if you've never done that first? You know what I'm saying? Or should I go the colonoscopy route? Second question is that, for example, I'm concerned about anesthesia because I've never been under anesthesia. So is that other option that you mentioned, and please forgive me, is that available would that be available, through my insurance or something like that? Or how should I ask for that? Does that make sense? I hope
Yes,
that question makes sense.
yes, yes. So thank you. Thank you for all that. So a double question. I can help you there. So with that first question that you brought up, I want to be able to say, at least from the beginning, I want to say that the fecal occult blood tests, those are more convenient, yes, but determining which one is better, that is an answer that you're going to have to get from your provider, whether it be like the colonoscopy or one of the fecal occult blood tests. They would be the ones to better help you with that. One's just more convenient. And then whenever it comes to the second question, that's a really good question, and I'm so glad that you brought that up because a lot of us don't know what our insurance covers. And if you look on the back of your insurance card, there is a helpline and you can contact the individual. So it's normally, maybe on mine it says nurse advocate. So you can contact them, or you can contact the insurance directly, the number for them directly that's on there as well, and then just ask them, okay, so is this procedure, the CT tomography, is this something that's covered by my insurance? Because sometimes it's not, and that's really unfortunate, but that's just how some of these organizations work,
Thank
unfortunately.
you so much for that response. I'm just trying to prepare myself because I'm not real cool with anesthesia, but I still have a whole other year before I do it. But I'm just saying, I'm trying to prepare for it.
As you should know, and that's a really good approach to take. Be better prepared and ready for these kinds of questions later.
Thank you. I love that question, right? Because it's always best to be proactive with our health. So thank you so much for the questions. And Dr. Bloom also put that those with precancerous polyps would have a shorter period of follow-up. So please um, stay in contact with your primary care or your provider so that they can guide you on the screenings, how often you should get screened. There's also another question in the chat from Rosalva Zavala Turner that says, how many types of colon cancer are there or exist?
I I'll just be honest with you. I do not have the answer to that. I'm sure there are pl I'm familiar with the different stages, but as far as specific types of colorectal cancers, I do not have that answer for you. I can look it up for you if you'd like to and get you that answer. That's not a problem.
Thank you, Ms. Turner. The best thing though is to get screened.
Yes, yes,
Yeah.
exactly.
Get screened. Yeah. And then our another question we have is, what are the earliest signs and symptoms that patients often ignore?
Oh, so this is something that I really didn't spend too much time on, but one of the things that we see with colorectal, with all cancers, that my team covers is you really don't start seeing symptoms until you're in a more advanced stage. So about stage 3 and up. And this, unfortunately, is this is one of those things where it really just kind of emphasizes the importance of going to get the colorectal cancer or getting the screening and knowing your family history and having those conversations with your doctor. Because I can't give you a most common symptom. I mean, yes, it is happening, in the lower abdomen, where this is all going, but you can't really pinpoint, or I don't have that information that there's one specific symptom that is most common, and my apologies for that, but I do at least want, and thank you for this question as well, emphasize or make sure everyone knows that one of the reasons why we need to be really proactive is because we tend to not notice things until it's a little late.
Mhm. Thank you. I will say that when in doubt, check. When in doubt, check.
Yes.
I will comment that because it's very important that if something, I think one of the things that you commented on about knowing your bodies or knowing yourself is very important. So if you notice that something's not right, or is different, then that's a reason to get just a checkup, at least that annual checkup. I think Miss Rosalva Zavala Turner has her hand up as well. Go ahead.
Um, in 2019, I was diagnosed. I didn't know I have a cancer in the colon. I I supposed to go for a gallbladder remover, and I ended got removing like several organs on my body. But the ones that really made me impact is because they find out, and I couldn't um when they do the X-ray, they told me, "Oh, ma'am, you need to change your clothing, and you're not gonna leave the hospital." I'm like, "What? Why? I just coming for remove the gallbladder." I said, "No, there's something else. You need to see the doctor." And after that, I stayed a month in the hospital because there were complications they did the surgery. They didn't connect all the organs together, and my body was disposing everything inside, so they have to reopen and clean it. And it was so, I didn't know how dangerous it was, but till later I started reading and looked at it, and like that's what I was thinking, like tumor, cancer, whatever, how they connect between that, because that's something I was into. It happens to me.
No, and you were very lucky that they were able to find, I mean, and at the same time, that the outcome was not the one that you wanted, having to stay in the hospital longer, but at least, they were able to treat the issue then and there after your gallbladder surgery, because a lot of us don't, again, we don't notice that something's wrong until the disease has progressed. So it's easier to treat early on. That's why the screening again is so important.
Thank you.
Mhm.
Also, we have a question in Spanish that says, how early, I'm going to translate it, and I hope I'm doing, if this is not the translation that you're asking or the question you're asking for, please correct me, but I think it says, how early can one start with colorectal cancer?
So oh, thank you for that. So just to confirm with the individual that put that in, is that correct?
Mael,
Okay. So when it comes to that, again, with the screening and the guidelines, sometimes the recommendations are there kind of as that guideline, what we're supposed to follow as a guide. But it really depends. I guess the time and the recommendations, the suggestions for the individual, the patient themselves really depends on what their provider who has been working with them it tells them they should be doing. So what's the plan of action depending on their history and their environment and their lifestyle?
Thank you so much. I think all those factors come into play. I did lose a sister-in-law to colon cancer, and she was 30. Thought she was going in with appendicitis, and she had stage 4 colon cancer. But I think ignoring the symptoms and her family history, she didn't know her mom had been adopted, so didn't know it was familial, in the family. So I think, like you said, if there's a change or we notice a change, not to ignore it, but to get screened. So any other questions or comments from the audience?
Would you also like me to respond to that question in Spanish?
I was going to ask that. Did it
Okay.
translate? Because I know there's a translation. So we're using
Oh,
translations.
okay.
Yeah, system.
Okay.
Miss Marta?
No, ma'am. If possible, we need to speak in Spanish because the translation is not very good.
Okay.
Thank
Sandra,
you.
you wanna,
Yes.
yeah, you wanna answer in Spanish?
I can go ahead and do that. So, ahorita no tenemos una edad que puedes decir que, ok, cuando llegas a esa edad es el más temprano que puedes hacer el screening. El recomendación del screening o cuando necesitas hacer este procedimiento depende en su historia familiar, depende en su situación, cómo comes, tu vida, su salud. Dependen todos esos diferentes factores para determinar, bueno, cuándo es el tiempo optimal para que empieces estos exámenes. Y es muy importante tener esa conversación y hablar libremente con su proveedor para que ellos te pueden determinar qué es el plan de acción para usted.
Thank you, gracias. También puso ahí la doctora Bloom, puso ahí algo en español en el chat, so si quiere leerlo, dice, depende de tu genética, a lo que comes, la actividad física, si fumas o si consumes alcohol. So, hay muchas variedades porque este puede tener más riesgos,
Riesgos, yeah.
riesgos, ajá, riesgos, dependiendo qué clase de vida vivemos. So, gracias. Let me see. Alguien más, someone else, anybody else, we don't want you to go with your question. And remember, no question is, well, I don't want to ask that. Maybe somebody else wants to ask it and don't feel comfortable. So if you feel like comfortable asking a question, please, this is the time. We are here to learn from each other. Okay, I have one more question in the chat and it says, es un mito que tomar vitamina A puede ser un factor. So is it a fact or a myth?
Yes.
Uh,
Okay, so en toda la información o la literatura en que yo conozco, yo tengo experiencia en, no he mirado ese factor o ese mito en cualquier es de la información que yo he leído. Sí puede ser, pero al punto que sí es algo que debes de preocuparse por. Yo no puedo comentar porque las cosas que están más comunes son las que estaban en la presentación. Ojalá que explique eso bien. But essentially, this factor right here, it has not come up as one of the main factors, and that was kind of, or one of the most common factors, and that it may be, but I have not included that in this presentation because it's not one of the most common factors.
So the question was asked if taking vitamin A can be a factor. And so we were clearing that it's not in the literature that, we have come across that it can be a factor. Perhaps with big amounts of vitamin A could be, but not anything that's in the literature. Dr. Bloom did put something also in the chat, and it's a long Spanish. So good luck to y'all. Miss Melinda?
Sorry, basically what seems to be in the literature is it's the metabolite retinoic acid. So when vitamin A breaks down, one of its components is retinoic acid, and that's the one that seems to be associated with formation of adenomas, a kind of the tumor. But actually, like the vitamin itself, beta carotene, have protected effects. So, but as mentioned by Ms. Sivak, there's really need to be studies on that one. So I would focus on getting your vitamin D, like avoiding smoking, alcohol, and eating healthy and having active lifestyle, and getting the screening would be the best way to go.
Thank you, Dr. Blum. Really appreciate that. Miss Melinda, did you have another question or comment?
Yes, thank you, Belinda. My next question is, so this is just, just something that came into my head as a thought. So say your colonoscopy was good. They told you you can come back in 3 years or 5 years, right? Whatever. But then you have something you find your body going through something different. Is it a good idea to go back? Do you think they'd recommend a colonoscopy or what? I know it's best to go back to your doctor when you see changes or feel changes, but you're in between that time, so in between the time frame. So what would be the best recommendation?
Yes, so having that conversation, but then also, I know that I had mentioned it in the presentation, and it might seem it might seem a little strange, but at least taking notes of these changes so that you can be a good historian whenever you do report it to your provider so that they can give you the best answer that they can based off of the description that you've provided. And they may opt for you to do additional testing or additional screening. They may not, but it really depends on the information that you give them.
Because if I'm correct, it can happen, right? Like you can go to colonoscopy, you have a good colonoscopy report, but then something can happen within those years, right? That would be right.
Yes, yes, exactly. And that's very true. Yes. But just making sure that the plan of action is appropriate for the symptoms that are being experienced or shared with the provider. It can be a little, I guess, less invasive if needed or more invasive if needed. Try to take the best approach with the patient.
Thank you. And you know what I like about you? It being, because it is a very touchy subject, very serious. You are so calm about it. And I like that. You know what I mean? Don't take it too serious because then you would have really scared all of us. Just wanted to say that comment.
I know we're all in the same boat, guys. Every single one of us.
Thank you so much. Any other questions? We have time for maybe one question or comment. If not, thank you so much, Sandra. We really appreciate it. What a great presentation. Again, another round of applause for our first presentation in this colorectal series, cancer series. So I want to thank you for being here. And at this time, I'm going to turn it over to Joe.